surgery for a while, so he'll be speaking on that.
Good afternoon, everyone. So I'll be talking about SALC now.
Can we have the attention, please?
LKs are currently the preferred mode of management of any forms of partial corneal opacification. However, we encounter a lot of graft failures on account of suture-related infections. And SALC or suture-related, the term is used interchangeably, either call it superficial or sutureless. Either way, this can be used for a host of conditions, including degenerations, basement membrane, and some forms of stromal dystrophies, and anterior corneal scars secondary to infections or trauma. Now, it's important to know where this surgery fits into the whole spectrum of lamellar procedures. So if you have a patient of partial corneal opacification, we need to address the depth of the opacity. So very superficial opacities less than about 100 microns would do well with PTK. As you start going deeper and deeper, PTK becomes less of an option because of the high hyperopic shift induced by PTKs. So depending on the depth, you could do an ALTK, LK, deep lamellar keratoplasty, and then finally DALK, where you just leave the stroma and the endothelium. So SALC fits somewhere in between PTK and ALTK, where PTK would be too less to remove the opacity and ALTK would be an overkill. You can do it both with the microkeratome system or the laser system. At RP Center, we are using the Moria microkeratome system to harvest the graft. If you have done LASIK using these microkeratomes, then it is just in the same way. The host is also cut in a similar fashion. You apply the micro suction ring on the host side and run the microkeratome. You get blades in different sizes, and generally we go up to 200 microns or less, because anything more than 200 microns you would need sutures to apply the graft. Following this, the host bed is dried, and as you would put back a free LASIK flap, you apply the graft. Generally, you might see some ovalization in the graft, so one can orient the graft on the ovalized part of the host and try to adjust it accordingly. And then you use a couple of Mirasil sponges to draw out the fluid using capillary action from the interface. And as you'll find that as you draw out more and more fluid, the graft will tend to stick on the cornea, and the glue is applied on the edges of the graft. Post-operatively, bandage contact lens is kept for 6 weeks. Antibiotics for 6 weeks, steroids initially a little frequently, and then tapered over an year, and preservative-free lubricants. These are a few examples of this surgery performed in various conditions. So as you can see that the graft generally clears up quite nicely after 6 weeks of surgery. Now this surgery can also be quite easily combined with the phaco if the patient has coexisting cataract. So what you do is that after you harvest the graft, you get a clear bed of the cornea. So at this point, you hold on to the graft, and you have just removed the host. The phaco resumes as in a normal case. And once you have done that, the only difference in these cases is that I like to put some air in the anterior chamber to have a taut host cornea. And I also like to apply a couple of sutures on the host cornea to have a very tight anterior chamber, and then these subsequent cases similar in nature. These are a couple of patients who underwent this surgery, the triple procedure with SALC. Now, a major issue with SALC is graft sizing, especially when you're using a microkeratome. So you would encounter two scenarios. Either the graft is too big or too small. If you have a larger graft, it's quite easy to handle. You measure the graft, you measure the host size, and keeping a 0.25 millimeter oversizing, you cut the graft, punch the graft again with a trephine and remove the peripheral rim, and then you can apply the recut graft accordingly. The more trickier problem was how to manage if you have a smaller graft. Now the one option was that you have a backup eye and you cut a fresh graft. But generally, if that machine on that particular day has cut say an 8.5 graft, it will again cut the similar graft even if you try to vary the pressure. So now what we have resorted to is, because we were getting a lot of smaller grafts, so what we do is we measure the size of the graft which has actually been cut and the cut which we wanted, and we add about, we subtract about 2.5 from that, and then we use the host cornea which was already been cut. Now these are corneas which are having degenerations or dystrophies, so as such there is no active disease process in them like an infection. And then what you get is a small rim, concentric rim of the cornea which you can apply in the defect which was left. I generally prefer to apply this concentric shaped host cornea, the part of the host cornea in the superior area which would be well covered by the lid, and then subsequently glue is applied. So this is a patient who had to undergo this technique. As you can see, on first post-operative day, the concentric graft is quite highlighted, and within a few months it merges quite well as its patient's own cornea. So we published these results a few years back in Cornea, and the take home from these results was that the patients recover vision very fast following this surgery, even if it is a plain SALC or SALC with phaco. So compared to a procedure like DALC or ALTK, where it takes about 6 months to 1 year to regain vision, in these cases the final visual acuity you almost reach by 6 weeks of surgery. The complications which you can expect in these cases are epithelial rejection, which we have seen, recurrence of pathology, especially things like granular dystrophies, they come back, and we haven't encountered any cases of graft infection as yet. To conclude, it's an effective technique for management of anterior corneal opacities. Its indication is where PTK is inadequate to treat the pathology, but rest of the suture-based surgeries are an overkill. It has a very short learning curve compared to some other lamellar surgery techniques. There is a much faster visual acuity recovery with a lower risk of graft infection because of absence of sutures. When combined with phacoemulsification, it greatly improves the visualization for the surgeon during the surgery. A couple of limitations: the best corrected visual acuity generally stops at around 612. Then there is an added cost of the keratome machine and the fibrin glue. Thank you.
Thank you, sir. Sir, a few questions. Is there any choice of patients like you select other than the depth of the scar, depth of the lesion? Is there any choice like deep set eyes or something which you exclude for?
So in extremely, the Moria keratome is an Asian model. So as such, it's designed for slightly smaller apertures. There are some other videos which I have, for lack of time, I didn't show. So if you have a smaller aperture or a very tight aperture, you can reverse the orientation from medial to lateral, and then it gives you a little more space. Then another trick is that when you block that patient, these are done under block. So don't use hylays in the mixture of the xylocaine mixture. So that will impede the dissipation of the xylocaine, and it sort of slightly gives you a couple of millimeters extra, which is all you need. So barring one case which I remember, which we just could not, the orbit was completely devoid of any fat, and it was just bone on which the spectrum was applied. That was one case where we couldn't proceed with the host cut. Barring that, I haven't had any instance where we had to sort of abandon the surgery because of the small aperture.
Okay, thank you, sir. Are there any questions from the audience? Okay, if not, we'll proceed to the next speaker.
Thank you, sir.
Thank you.
Go ahead. Yes, Bhaskar.
Dr. Bhaskar is a cornea and refractive consultant in Shankar Nethralaya, Chennai, and he'll be talking on MMG in SJS.
Very good afternoon, and I would like to thank the AIOS organizing committee for giving me the chance to be a part of the CORNEA SUB-DAY. So basically, when looking at an acute SJS, it's a severe cutaneous adverse reaction, and we do know that in the acute phase,
आगे आ गया.
So in the acute phase, there is a definite role of amniotic membrane transplantation, and you might have to start the patient on systemic cyclosporin or systemic steroids. In the chronic phase, you have various manifestations, but the one manifestation which seems to make a significant impact on long-term vision of these patients is lid margin keratinization, because that causes blink-related microtrauma leading to a constant damage to the ocular surface. So this is how a lid margin keratinization looks when it's very severe. And if you're looking at incidence, in our study we found almost about 70% of patients had lid margin keratinization if you actually go and look for it. And you can actually see that the area of the keratinization actually corresponds to the area of significant staining on the ocular surface. Between the upper lid and the lower lid, because of the excursion of the upper lid is more, you will tend to have more of an effect if the LMK is more in the upper lid as compared to the lower lid. But sometimes it might be very subtle, where you actually just in a diffuse illumination you might not be able to see. If you stain with fluorescein, you will see it as a negative stained area, because when it assumes skin-like consistency, the fluid will not be on that area. So negative staining at the lid margin would indicate an early keratinization, and that's something that you need to address, otherwise you will end up with small perforations and finally an end-stage ocular surface failure. What are the treatment options? You have bandage contact lens, you have scleral contact lenses, you have the option of mucous membrane grafting, and sometimes you might have to combine both the mucous membrane grafting with a pros lens for better vision. What is the decision making which decides whether you would want to operate this would depend on the grade of the LMK, would depend on the patient's symptoms, the corneal damage, the surface keratinization, and if you're planning any intraocular procedure. In terms of technique, it's a fairly simple procedure, but you have to got to do it right. So you take lid sutures to get a good exposure of the area. You evert it over either two Wexel buds or two Johnson's buds, or you can take two sutures and evert it over the back end of any flat instrument. The plane of dissection is between the conjunctiva and the tarsal plate. So unlike what the oculoplasty people do in terms of the skin and the muscle on one side and the tarsal plate and the conjunctiva on the other side, we are basically dissecting between the conjunctiva and the tarsal plate. So the amount of tissue that you're removing is going to be much more thinner as compared to what we conventionally do with the oculoplastic surgeons. It's important not to damage the tarsal plate as much as possible, but if you have a lot of districhiatic lashes, you might want to include them in your dissection. The harvesting of the oral mucosa is fairly simple, where you need to take a little bit larger, because there is a tendency for the mucosa to shrink, and you'd probably, if you're doing a bilateral procedure, you'll probably need somewhere around a 40 centimeter by 10 centimeter width of the tissue, so that you can use it for all four lids as such. The mucosa, you can either leave it to heal by secondary intention, or you can suture it. We prefer to suture it so that the patients are a little bit more comfortable in the early post-operative period, and you can take a mattress suture, or you can take an interlocking suture, so that you are able to tightly oppose it. It's important to thin the mucosa, because the conjunctiva that you are removing is thin. The mucosa also has to be as thin, because you don't want it to be thick, in which case there will be an increased friction between the lid and the cornea. So you can wrap it around your fingers and just thin it out. And then you are placing it on the lid margin, you are suturing it at the anterior portion so that you can stretch the tissue nicely, and the posterior portion you can stick it with fibrin glue. Here it's important that your mucosa doesn't go beyond the area of defect, because if you have the mucosa going on top of the residual conjunctiva, you will have conjunctiva growing under the mucosa, which will result in a necrosis of your tissue. So your tissue that you're putting has to be slightly smaller than the bare area that you are leaving in the lid margin. The suturing is similar for the upper lid and the lower lid, and that pretty much is what you would need to do. And most times these patients are pretty comfortable post-operatively. You can actually leave the conjunctiva there, so you're sure that you are not going to overlap your mucosa with the residual conjunctiva. And then once you stick it with glue, when you are removing your speculum, you need to be careful that you don't pull or yank the tissue, because the fibrin clot can kind of get dislodged. So if there's any tag, it's better to just cut it with a scissor rather than try to just tease it with a spatula or an instrument as such. Sometimes when you are dissecting the upper lid or the lower lid, there can be a slight variation in techniques, which we'll see next in this. Yeah, so meticulous removal of the glue. And so here I'm using the back end of an instrument. I've used two lid speculum. So this also gives you a good counter traction, so your bleeding can actually be reduced by just pulling the tissue up, so that there's a tautness to it. You can actually see the reflection of the 15 number blade under the conjunctiva that tells you that you are superficial, and that's the dissection plane that you would want to maintain. And you can actually see that shining tarsus as you are reflecting the overlying keratinized conjunctiva. So for the lower lid, sometimes you can, if you feel that you're not getting a counter traction, you can start the dissection even from the conjunctival side. So once you make it, you can just do it like how you do it in SICS. You can use a crescent. Again, you need to see the reflection of the instrument under the conjunctiva to know that you are superficial. Because if you're going to use this way of dissecting it, it's very easy to actually go into the tarsal plate and end up removing a tarsal, which will actually cause a bit of an entropion once the surgery is done. And then you're making a groove at the lid margin. The incision side of the lid margin is just behind the meibomian gland orifice, and then you are removing off the tissue. So you have a bare area, you measure the area, and you harvest the tissue. If you are using the mucosa for, say, a surface reconstruction, and you want a very thin mucosa, you can again do a similar process where you are just using the crescent on the mucosal surface to get a thinner graft, so your dissection time becomes lesser. But you can't do it if you're doing it for all 4 lids, because it kind of breaks. So if you're doing it only for 2 lids, you can probably use this way so that the time that you spend on thinning the tissue by wrapping it over the fingers is reduced. And if you have to combine it with the fornix reconstruction, instead of splitting the conjunctiva at the limbus, you can actually cut it at the lid margin, push that conjunctiva down, so that forms a part of the bulbar area. So you have a broad area on the tarsal surface where you can put a broad mucous membrane graft. So for any surface reconstruction procedure, you would ideally want both the surfaces epithelialized. So here you have a broad mucosa which is covering from the lid margin till the fornix, and here you have the conjunctiva which is going deeper into the fornix to get a reasonable depth. So with just that one surgery, without having to use amniotic, you are getting your fornix reconstruction and your lid margin keratinization both addressed. Post-operatively, we probably don't need any topical steroids. We normally remove the sutures by a week to 10 days time, and in fact by day 2, day 3, the eye will significantly quieten. This is a patient who was using contact lenses for the last 15 years, and she said that she could never open the eyes without a contact lens, and this is second day post-op where she was comfortably opening the eye. You might even see an improvement in the ocular luster and the clarity as the friction component reduces. You can see the haze coming down, you can see the vascularization coming down post mucous membrane graft. This patient refused MMG when we first advised it. One eye was lost, and the other eye, when it got worse, we did it, so at least we were able to stabilize it in the second eye before we lost that eye also to an end stage ocular surface failure. Like I said, your mucosa should not be very thick. If you are making a mucosa thick, then the entire reason for which you are doing the procedure in terms of a blink related microtrauma gets negated, because you are actually worsening the surface rather than improving it. Again, if there is a recurrence of the keratinization, you might have to redo the procedure. If the mucosa necroses off, and that will happen only if there is a conjunctiva which is growing under it, or your glue has not got, the mucosa has not got stuck properly to the base. So make sure that you stick it properly, just a couple of seconds. Recurrence is easy to manage. Frequently asked questions, what is the plane of dissection? We've already mentioned that it's between the conjunctiva and the tarsus. Age limit, there's no specific age limit. Only thing is, if the patient has a recent onset of SJS, you will wait for the mucosa to heal, after which only you will take the patient up for surgery. Our youngest has been about a year. Whether local anesthesia or general anesthesia, we prefer general anesthesia if you're going to do all 4 lids. If you're going to be doing 2 lids, you could do it under local anesthesia. Size of the graft depends on the area of defect that is created. People do ask whether we are worried about rejection. Obviously not, because it's an autologous tissue, but what we are worried about is a necrosis of the tissue because it has not been placed correctly. Complications: too thick a mucosa, recurrence of keratinization, or a loss of graft because of necrosis. Long-term results are pretty good. This was a patient whom we did MMG in 2006, and this is now almost, then she was wearing a prose lens, and this is almost recently, about a couple of years back. So it's almost like a 14-15 year period, and she's now pursuing her studies. This was one of our patients in 2006, operated. He's studying, he's now in NASA doing some research work there. Thank you.
Thank you, sir. So one question for Dr. Bhaskar was that if you just mentioned about recurrence in cases of keratinization. So what is the management like? You do sectoral MMG or in those cases or complete?
You can do a sectoral, but the problem is wherever you have the edges, you will have a sliver of mucous keratinization kind of sticking in. So if there is a recurrence, I would want to see if sometimes if your mucosa is slightly thicker, it probably helps you because the recurrent thing doesn't rub it. So I would want to still look at the surface. I would look at where the recurrence is. If obviously that area there is increase in keratin, increase in surface staining, that means I need to address that. I would probably put a broader tissue again rather than just putting a small sliver of tissue there.
Thank you, sir.
Any other question, comments for Bhaskar?
Generally a month is fine because the mucosa takes up in about 10 days time. By 10th day, if you don't see the mucosa to be vascularized, you know it is going to necrosome. So that's the reason why we ask patients to be there for a week's time. By the 3rd, 4th day, you see spotty vascularization. By a week, it vascularizes. By a month, the junction is healed. So then you are not worried about any manipulation.
Okay. Now the next session will be by Dr. Sayan Basu on stem cells, hydrogel and 3D printed corneas. He heads the research department and is the head of the Oculus Office department in LV Prasad Eye Institute.
Thank you so much, Prajakta. Good afternoon, everybody. Thank you for having me as a part of the Subspecialty Day. I think it's a wonderful initiative. Lovely to see all of you here in this but packed room, and it's wonderful to be back in the city that I grew up in. So I'm going to talk to you briefly about stem cells, hydrogels, and 3D printed corneas in the context of corneal regeneration. I have a couple of disclosures. There are a few patents that are out on the products that I'm going to describe, and a lot of this research is funded by different organizations, some from the government and some from philanthropic support. So one thing that we must understand at the beginning of this presentation is currently all of these things are very tightly regulated in India. So every new product that you want to use, particularly stem cells or any bioengineered products, are regulated as new drugs, and they have to follow all the regulations that you need to follow to get any new drug into the market. So the entire opportunity that we had earlier of doing academic research in this area is gone. It has to be developed just like any new drug, which makes it a little bit complex. There are, you also cannot make any claims until the time that these are approved as therapy. So this is the framework within which we are working right now. What this means is that it makes the process very long. So this is currently the pipeline of products that we have at LVPI that we are developing in this area. There are other products in retina and other areas that I'm not talking about. But as you can understand that even preclinical, before you go to clinical trials, you have to do a lot of work in the lab on setting up the GMP production protocols, and this is usually after you've done the proof of concept studies, etc. Then get the manufacturing license, then do the preclinical studies. So this pathway itself takes anywhere between 3 to 5 years. And after you have completed this, then you come to the clinical trials. And there again you have to go from phase 0 to phase 1, 2, 3, 4. And so this is again, you're looking at anywhere between 5 to 10 years. So this is important to understand that, those of you who are looking to innovate in this area, please be prepared for the regulatory, considerations. And it's not very easy to get to where you want to get. The other piece of advice that I have for people who are working in this area is, other than understanding the regulations, is also, identify a problem that is specific to India and where, cell therapy or gene therapy can bridge a gap, and focus on solid science, collaborate, partner, and make sure that whatever you're developing, don't get excited only by the possibility of what it can do, but also make sure that it doesn't cause any harm, and try to find a solution that is not only effective, but also affordable and practical, because most of the people who suffer from these problems are not able to afford very costly therapy. So we are trying to develop a product that is not $1 million therapy, that is something that is affordable to most people who have this problem. So the problem that we have selected is corneal stromal opacification, which is the #1 cause of corneal blindness in India. This is very different from the West, where it is mostly endothelial disorders or keratoconus. In India, these are post-infectious or post-traumatic scars. And if you look at stromal regeneration, which is what we are trying to aim for, you can either approach this through, regenerating or using an approach which uses keratocytes, which are the cells that produce the extracellular matrix, or you can use a combination of this. So I'm going to tell you about all of these different approaches. It's also important that you have a way of assessing what you're trying to treat. So we have developed these in vivo metrics through which we can figure out if the treatment that we are using is working through clinical imaging modalities, and also how you define what you're trying to treat. So you have to understand that it is not correct to simplify a corneal opacity that is causing visual impairment or blindness simply as how dense the scar is, because there are other elements to it. There is also irregularity, there's thinning. So a scar is not just an opacity, it is a combination of opacity, thinning or flattening and irregularity. So just making the cornea clear again will not help the patient see. You have to address all of these components. And then for all the preclinical work that I showed, it's important to develop animal models as well. So keratocytes and mesenchymal cells for corneal regeneration is what we worked on first. Our initial plan was to use autologous cells from the patient, but this is again from regulatory considerations very difficult. So right now we use allogenic cells which are derived from cadaveric corneoscleral rims which we get from our eye bank. We also use alginate for preservation. This is important because it allows for room temperature preservation of these cells, which means that once these cells are available, we can transport them to any of you around the country without having to maintain a cold chain, which significantly brings down the cost of this therapy. We have a GMP facility in-house at LVPI where these cells are manufactured. And before getting to the clinical trials, we made sure that these cells were safe, that they were efficacious both as prophylactic and therapeutic when we applied it for corneal scars and other corneal pathologies. And we have just completed 2 approved clinical trials, both with unpreserved and preserved cells. And the framework of both these trials was similar. We were working with superficial corneal pathologies, and the 2 trials, each of them had 20 eyes of 20 patients with either scars or necrosis or burns. This is how we make our cells. They are, like I said, derived from the cadaveric corneoscleral rims. So these rims are obtained from the eye bank. You obtain the limbus from them, digest it, and then once you have digested the limbus, then you grow them out. Initially you get a mixed population of epithelial and mesenchymal cells, but eventually you can get a pure population of mesenchymal glue, which is applied on just get a week of antibiotics. So we use very objective outcome measures to look at this, and as you can see from these photographs, typically this is the response that we see in scars. On your left is a superficial scar, on your right is that scar significantly ameliorated after months of therapy. And we also see improvement in other parameters as well, and this is what we are doing right now. We have to follow these patients up for 2 years before we can initiate the multicentric trial, which I hope some of you who are interested can participate in. So we got very good results with our mesenchymal cells, and like I said, we are following these up for seeking approval for multicentric trials.
Thank you, sir. It does seem like magic. And
It is magic.
so there's one question which was bothering me, like is there endothelium also there in neocornea, or it can be used for DALC?
You can theoretically put endothelium also. We are focusing on the treatment of scars, so we are, our focus has always been on stromal regeneration, and Jord is the right person to talk about endothelium. And if he can give us the endothelial cells, then we can definitely layer them on any substitute.
Yes.
We are working on an idea that you may not need endothelium. Full thickness corneal transplant, so that maybe in a year or 2 years maybe we'll have some animal study outcomes.
Thank you, sir. Are there any questions?
Any question, comments, anyone from the audience?
Chalo, thank you so much, Projector. Thank you, Domo.
Our next speaker is none other than the inventor of SLED, Dr. Virendra Sangwan, and he's a director and innovation at Shroff's Charity Eye Center right now in Delhi, and he'll be speaking on the SLED revolution. There's no stopping it.
All right, thank you very much, and very briefly I'll talk about the SLED and what it has reached. This is a patient who we saw in sometime 2006 when he underwent a LASIK, and followed that he developed a fungal infection. He works in London, came back to Gujarat, and there he was told that it's very difficult to save the eye. The LASIK flap was amputated, but then he underwent a large therapeutic graft at LVP, followed by a cultivated limbal epithelial transplant, and then followed by a PK with cataract surgery, and at least 50-60% of his vision was restored. We will skip this part because this audience is quite well versed with the limbal stem cell deficiency, and the treatment of which we started way back in 2000 in LVP, starting with the cultivated limbal epithelial transplantation of harvesting the limbus, growing the cells on the seat of amniotic membrane, and then transplanting back. And this is how that surgery we have been doing. And there is extensive literature created on this particular topic, and success of these transplant over 10-12 years. The problem we started thinking with the cultivated limbal epithelial transplant is it's very expensive, and most of the clinicians will not have access to this. Therefore, and also in pediatric limbal stem cell deficiency, the outcomes are suboptimal. So we started thinking how we can start, innovating or simplifying this limbal stem cell transplant, and that's where the technique of SLED was developed. Started somewhere in 2009, and 2012 we published the first paper. The technique is widely practiced. This is the first, I think, the largest paper that Cyan published on this topic, and till date, I think, still remains the largest paper, with a very extensive outcome, both two, three outcomes that were very important here, demonstrating that adults and children LSCD both are equally responsive to SLED. The visual outcome are also comparable, and also whether the SLED is done by a fully trained or experienced surgeon versus a trainee, both were equivalent, and this technique is very easy to teach. These are some at the cell level, the validation that these are not what we are seeing. There is at cellular level, there is a reconstitution of the epithelium. These are outcomes before and after. This is 3-year follow-up, and this is a 10-12-year follow-up, and I hope that Cyan and his team will come out with a paper with at least 10-year follow-up of SLED, where we can demonstrate the stability of these results, which are achieved in short 3-4 years follow-up. Both of these patients are having 10-12 year follow-up, and these are confocal microscopy, and these are the slides contributed by Sapna from LVP. And so you can see the stability of the results and reconstitution. Another feature, patient undergoing SLED, we notice that there is a continuous stromal clearing, and that is the basis that Cyan just now showed about stromal keratocyte-based treatment of the corneal scars. So here you see this patient did not want further surgeries, and if you wait long enough, the cornea continues to clear. And this probably is the work of the mesenchymal cells that are part of the explant. The pediatric, like this is a slide contributed by Vikas, who has been doing a SLED from a long time. This is a pediatric patient with 14-year follow-up. This is pre-op and that 14 years follow-up. This is a innovation which Swati Kalki from LVP for the use of SLED in primary excision of OSSN. If the OSSN is like on the upper less than 2 or 3 clock hours, probably you don't need anything. If it's more than that, like lower pictures, you would need a combination of the primary SLED with the excision. And earlier I had seen that patient who underwent OSSN excision and chemotherapy and developed limbal stem cell deficiency, their outcome with CLED were not very good. So I think this is a very smart and good innovation in a far good management of OSSN, especially those are very large. Then there are many other innovations reported by different groups. This is another large study by a multi-center trial where surgeons from different cities in India and different countries collated their results and showed exactly what we had shown in 2016 in ophthalmology paper. This is a repeat where the clat failed, the slat is successful. So when you look at these 7 parameters, to me it looks like the slat scores on all the parameters among the 3 techniques which are prevalent. These are further modifications. And now you are seeing papers. This is like from Boris Malgun's group in Moscow. They have shown you don't need a amniotic membrane or you don't need a fibrin glue. So you can still do limbal this slat and it works very well. You would see that if you look at the publications and the number of reports from different countries, it's really grown global. And this is the global picture. And the publications, when now if you last looked at around 80 or 90 publications till date. Most important, I think, is this slide where we've shown that the cost of doing slat is 1/10 of the clat. Number 2, it is the true democratization of the technology where everyone who can learn wherever they are based, you really don't need anything other than your patient and your instruments. So in summary, this technique is very effective, replicable, repeatable, affordable and reliable, and it's really a platform technology which allows innovation by different surgeons around the world. Thank you very much.
Thank you, sir. So it always seems impossible until it is done, which Dr. Sangwan's line says, and it is very true. Slat is a true example of it. Any questions?
So, if you are planning a keratoplasty, so after how many months of slat would you plan, or do you do it together? Slat with a PK?
As my bias is probably if you have to first do a slat and then wait for at least 9 to 12 months. When you see that okay, your slat procedure is successful, then you can do the procedure. And this duration we came from learning from our clat. That data was published again, Science has published in I think AJO many years back. Clat, a PK followed by clat. So 9 to 12 months will be good. If there is a situation like you have perforation big enough that you are not able to manage, then it's okay to combine PK with slat. Yeah, especially I have seen Sapna's case and Pragna's cases that they have done a few cases and very good outcome. So we have some few time if you, next session. Thank you very much. Yeah, go ahead. Cadaveric slat for optical purposes, yes, if you want to do, it may be reasonable, but you will have to use immunosuppression. If you are doing for surface epithelial healing, then probably it does not matter the vessels come or not, as long as the epithelium comes back. For that, you don't need systemic immunosuppression.
Sir, regarding the alloslat in pediatric patient, alloslat. So, what's about the immunosuppression, sir?
Immunosuppression, that what I prefer to use is 3 drugs: systemic steroids, cyclosporin, and azathioprine. So, cyclosporin now you can substitute with tacrolimus because of wide availability and maybe the cost have gone down. But I have been using since 2001-2002 cyclosporin, so I'm quite okay with using these medications.
And regarding your papers, whatever I learned from everything from you, sir, have you mentioned the IVMP before the surgery? Or like
I do practice that in patients with alloslat, I give a dose of IVMP on the day of surgery, on the next day, and then also start on oral steroids. And at 48-72 hours before that, I start on oral cyclosporin to build the serum cyclosporin level.
If you plan for the tacrolimus, then should it start prior to that? Because
yes, exactly.
The 4 weeks time on
yes, 48 to 72 hours before.
Yeah. Thank you very much.
Thank you. Thank you, everyone.
Thank you, everyone. I'll request all the speakers to come together for a quick photograph.
Is Bhaskar here?